Today's presentation will describe how the mental health effects of developmental coordination disorder, DCD, impacts children, adolescents, and adults. I will propose that mental health supports in childhood, targeted at the commonly reported mental health effects of DCD, can mitigate these long-term effects. Please note, I will use DCD for the remainder of this presentation. So, my working hypothesis that I set out to explore is that emerging research suggests that early mental health supports are as important to helping kids with DCD as occupational and physical therapy. And I want to better understand what this means for us as therapists working with children, adolescents, and young adults. So, who am I? My name is Sarah Knox, and I'm a first year student in the Masters of Counseling Psychology program at Yorkville University. I am making a mid career transition into counseling. I have an MA in curriculum from the University of Toronto and a BA in international studies and gender from Trent University. I currently work in health policy with a focus on equity, maternal child health, and reproductive justice. When I complete my degree at Yorkville University, I hope to work with people across the life spectrum, but particularly with adolescents and young adults as they transition into adulthood. I also have a child who was diagnosed with DCD at age 6, and this research is directed by this personal experience. As a counseling psychology student, I'm building my knowledge and awareness of evidence based interventions. In particular, I'm interested in learning about building self efficacy and resilience in clients. I hope that cultivating these skills in individuals might generally be beneficial and have a particularly positive impact for people with DCD. My objectives for this presentation are somewhat exploratory. I will lay the foundation by describing DCD, its symptoms, and diagnosis. I will then describe the typical mental health challenges experienced not only by children, but also by adolescents and adults with DCD. I review what treatment approaches could be beneficial, and I will wrap up by examining the possibility of developing a model of therapy that can be delivered to children to prevent or minimize future mental health challenges. Understanding DCD. In this section, I will look at what DCD is, including the common mental health issues that arise. So, to begin to understand the link between coordination issues and mental health, I think it is important to understand how challenging the world can be for people who are diagnosed with DCD. Kids have a hard time with things like going up and down stairs and playing in the schoolyard. Adolescents have a hard time in school and are often lonely and isolated because they can't do what their peers are doing more naturally. Adults fail to reach their potential because they have been unable to learn the skills they need to succeed. When I first learned about DCD, I read that adults do well in jobs like being a greeter at a store or as companions for seniors. Very simply put, the APA recognizes DCD as a neurodevelopmental disorder that affects coordination. This is not a learning disability, though it affects learning potential. DCD is also sometimes called dyspraxia, especially in the UK. It was formerly called the clumsy child syndrome, but this term is now out of date. And initially, it was thought that children would grow out of their clumsiness, but generally they do not. And sometimes their symptoms are less severe as the person ages. The prevalence of DCD is quite similar to that of ADHD, though it is less well known. More boys are diagnosed with DCD than girls. The primary symptoms experienced by those with DCD are essentially challenges with fine and gross motor skills, motor planning, and coordination. I've provided some common examples here, but of possible greater significance are the secondary symptoms, which are psychological and psychosocial. These symptoms are potentially more concerning than that motor issues themselves because while poor coordination is frustrating and stigmatizing, the burden of mental health symptoms is far more impactful. Secondary symptoms include reduced participation in social life and work, low self regard, and depression and anxiety. Secondary symptoms can begin early in life. Some studies say by age 9 or even earlier. All symptoms of DCD, both the physical and emotional, are pervasive among those with the diagnosis and usually persist throughout their lifetime. Diagnosis. Diagnosis of DCD is done by a team with input from occupational therapists, educators, and caregivers. Criteria D must be assessed by a physician or pediatrician to make sure that the symptoms have no other known cause. Several conditions, like, for example, autism spectrum disorder and ADHD, have overlapping symptoms and multiple diagnoses may be given. A thorough health history of the child and other family members is completed, along with standardized tools such as the Movement Assessment Battery for Children, the MABC, or the Peabody Developmental Motor Scales. Typically, a child will be assessed for strength, balance, coordination, visual motor skills, fine motor, and graphomotor, i.e., handwriting skills. DCD is typically diagnosed after the age 5. Mental health concerns. There is growing evidence of a link between low motor functioning and significant negative impacts on social and emotional well being, though this link is still poorly understood. Poor psychosocial status in those with low motor competence is evident in the literature. So, what is this link? Poor self concept, self efficacy, social support, negative peer interactions all contribute to lower rates of participation at all ages and also to a reported lower quality of life. Social isolation, negative self regard, and a chronic sense of failure can lead to psychiatric disorders like anxiety and depression. Theories suggest that a sense of failure is pervasive and bullying is common. Children with DCD have a sense that they are standing on the sidelines, unable to keep up or participate in a range of activities at home, at school, and in their communities. Mental health supports. While children with DCD are not expected to grow out of the condition and there is no cure, there are steps that can be taken to minimize the negative mental health outcomes, and these include psychological and social interventions. Part of the problem at this time is that much of the research on DCD is recent and mostly focuses on diagnosis and identification, but there are things that do help. Research on how to support kids with DCD is mostly in the domain of occupational health, and the emphasis is on how to help children build motor planning skills. For example, the co op cognitive strategy, which is goal, plan, do, check, or on how to develop proficiency in tasks, specific tasks like handwriting, throwing a ball, or riding a bike. There is some evidence to help with the secondary symptoms, primarily from qualitative studies. Examples include supporting families to participate in activities outside of school where the individual can develop a friend group, for example, a walking group or a gardening club. Developing social skills and the confidence to find a friend group and school based activities where they feel that they can be successful, for example, joining the drama club, choir, or yearbook club. Developing skills of self advocacy so individuals can choose which tasks they can do and get accommodation if it's helpful to them. For example, they can learn to explain what they need and offer solutions like, I can do all 10 of these math questions, but I can only write out 2 of them. Can I get someone to scribe the other ones for me? Another example is working with families to create a home environment designed to support confidence and self advocacy. For example, set tasks that the child can do, like making a bed rather than washing or breaking the dishes. And working with the school to reduce bullying and support accommodation when needed. For example, not requiring all work to be handwritten. So, what's next? We know that DCD and just generally a lack of coordination and fitting in has lifelong mental health impacts. It may be possible to avoid these long term impacts by directly and proactively addressing some of the specific issues reported in the literature. While more research is needed, there are several factors at play that suggest simply acting now to support kids who fit the DCD profile addresses an urgent need. So, given that DCD is not as well known as some of the other diagnoses like ADHD and dyslexia, and that DCD is underdiagnosed and requires significant screening and diagnosis process, which may be out of reach for many people, and that the mental health skills identified here are helpful to all kinds of kids who are struggling in school for all kinds of reasons. The question I pose is, why not act now in our practices and look for opportunities to identify and help kids who are struggling with the fallout from coordination issues. But in the longer term, perhaps while we wait for additional research to emerge over the next few years, other approaches could be considered, like this example that I'm offering here. Obviously and ideally, there would be a longitudinal study of individuals diagnosed with DCD in childhood that assesses their mental health outcomes in adolescence and adulthood for a group that received mental health intervention early, as compared to a traditionally developing cohort and a cohort of similarly matched adults with DCD. So I'd like to take your questions now, if you have any, and thank you for listening to my presentation today.